Hey, I am Diana Castillo, and I will be presenting a case study on a patient that I had in the emergency department of Moses Cone. Mr. J is a 51-year-old man. He was admitted to the emergency department for hemorrhagic shock and hematuria. He has a history of hypertension, seizure disorder, anxiety, alcohol abuse, and as of January, a traumatic brain injury. This brain injury left Mr. J very dependent on a long-term care facility and also on a permanent tracheostomy with ventilation, a PEG tube, and an indwelling catheter. His arrival to the ED was due to a problem with his indwelling catheter. According to the healthcare facility that he lives in, Mr. J's catheter had become clogged, and when they attempted to irrigate the bladder through a size 28 catheter, his output was very bloody. So they decided to bring him into the emergency department. There's no knowledge of why a size 28 catheter was placed in Mr. J, but it's certain that this large size catheter caused some trauma to his urethra. And later we'll learn about some of the repercussions of this trauma. So looking at just his assessment and his vitals upon arrival to the emergency department, his temperature was 98.9, respirations were 20, his pulse was 72, his blood pressure was 79/47, and his pulse ox was 96 on 5 liters of oxygen. So everything was normal with his vitals except for his blood pressure, which was very low. A focused head-to-toe assessment found that his abdomen was distended and taut, and after using a bladder scanner, we found very little amounts of urine in his bladder, but this suggested that there was a chance that distension was due to hemorrhage from trauma to his urethra. He had hypoactive bowel sounds, his skin was very cool to touch, and he had some generalized edema. And these and other things were signs that he was not adequately perfusing to his extremities. His breath sounds had diminished bilaterally, and he was coughing up thick green secretions from his tracheostomy, and we had to suction him quite frequently. Later, a CT scan showed that Mr. J had begun to develop pneumonia in both lungs. He scored a 9 on the Glasgow Coma Scale, and his pupils were non-reactive to light. Though Mr. J could not speak, his facial expressions and body language communicated that he was in a great deal of pain, and his movements were almost seizure-like activity, so it was difficult to determine whether he was having a seizure or responding to pain, but we tried to respond appropriately to these efforts of him communicating with us. The area around his indwelling catheter was very bloody, and his genitalia was quite swollen from the trauma. Some things that we did immediately as he arrived to the emergency department and we assessed him is that we began a bolus of normal saline to try and return his blood pressure to a normal range. The doctor also ordered norepinephrine or Levophed to try and correct this low blood pressure, and this required consistent monitoring as Levophed is a very powerful vasopressor. We also administered lorazepam or Ativan as a mild sedative to help him deal with the pain and seizure-like activity and just calm him down with his situation. As we move on to looking at fluid and electrolyte balance, once we got the results of Mr. J's basic metabolic panel, we saw that his sodium and his chloride were both low. And both of these things could be due to the fact that he had lost a great deal of blood from his bladder, but it could also be due to the fact that there was There seemed to be evidence of some kidney failure as his BUN and creatinine levels were elevated in his BNP as well. So with hopes of increasing both sodium and chloride levels, we continued to administer normal saline to our patient while he was with us. Mr. J's acid-base balance was in normal standing, but prolonged bleeding and just complications of his state could create a imbalance in acid base and would put this patient at risk for developing even greater problems. And so we tried to maintain good hydration, good oxygenation for him so that he wouldn't develop any problems with acid-base balance. When we look at immune system and infection, the only signs of infection that Mr. J had were the green secretions from his trach tube and also the chest x-ray that was positive for pneumonia. Though there were no other signs of infection, Mr. J is at great risk for developing various types of infections because, one, he resides in a healthcare facility, two, he is immobile and bedbound, and three, he has 3 clear entryways from the outside into his body through his trach tube, his PEG tube, and his indwelling catheter. It's very important for us as nurses and healthcare professionals to maintain aseptic technique as we cleaned and managed the various tubes of this patient because there's great risk for developing sepsis through these entryways to the body. We did start Mr. J on a vancomycin drip to treat his pneumonia infection. And overall just tried to prevent any further infection with him. When we look at hemorrhage and clotting, as the larger catheter was removed by the urologist to try and drain his bladder, the patient drained about 1.5 liters of blood, which is a lot. And even as we began continuous bladder irrigation, he continued to drain blood up until the following day. And because of his great loss of blood, his hemoglobin, hematocrit, platelet count were all very low, and we began